Hello and welcome. My name is Kerran Vigroux and I'm the director of the City of Lowell's Health and Human Services Department. I'm here today with Dr. Tom Stopka from the Tufts University School of Medicine, and also with Amanda Shaw, and she is from Lowell House, and she is a recovery coach and outreach supervisor there. We're here today to talk about the opioid crisis in the city of Lowell and all around our country, and also what we're seeing here as far as a increase in HIV and hepatitis, and what's really happening in our community and what we are doing and our community partners are doing to work on this problem. So thank you for being here with me today. Just want us to be comfortable and talk to the people at home to try and answer some of the questions that we hear often from people that we work with and also people who live in our community about what's happening here in Lowell. So Tom, I'd like to start with you and just ask a little bit about the history of opioid use in general and how that has affected and transitioned to injection drug use and how that's affecting our community.
Sure, and first thanks Kerran, and thanks to LTC for having me here today and having us here in this forum. It's an important topic. So prescription opioid use really is what increased pretty substantially in the early mid-2000s, not only in Massachusetts, not only in Lowell, but across the US. In New England, we've been particularly hard hit, and over about a decade, we were seeing pretty steep increases in misuse of prescription opioids. Some people might have started using prescription opioids for valid reasons, maybe pain, maybe an injury, maybe post-op, surgery. But some folks transitioned into misuse or addiction, the disease of addiction. And over the years, public health officials, clinicians started to realize that we needed to do something to try to change or decrease the flow of prescription opioids or be more careful about the way in which they're being prescribed. Many people then, over the years, may have transitioned from prescription opioids to illicit substance use. One, because maybe their doctor cut off their prescription because they said, it's well after your surgery, well after your pain should have subsided, it's time to stop the prescription. But if the person's in the throes of addiction, it's hard to just stop cold turkey, and they might have then sought prescription opioids on the street, sold on the streets, but that's very expensive and can be hard to find, particularly now that there's been a stronger response to decrease the flow of prescription opioids. Then folks would, if they're still in the throes of addiction, may transition to heroin. Heroin is very easily obtained. It's ubiquitous throughout our community, not only in cities, but in suburban and rural communities across Massachusetts. And it's cheap. It's quite cheap compared to prescription opioids and pills on the street. So in Massachusetts, from 2000 to 2016, we've seen a huge increase in opioid overdoses, non-fatal and fatal overdose deaths. And from 2000 to 2016, we saw nearly a quintupling of fatalities related to opioid overdose. In Lowell, the number of overdose deaths have climbed steadily over that time frame. In recent years, we've seen it climb above 50, 60, nearly 70 overdoses, fatal overdoses in a year in the city of Lowell. The county of Merrimack, or Middlesex County, within which Lowell sits, has the highest number of overdose deaths of all counties in Massachusetts. So the problem is substantial, and Lowell itself has seen large increases. And on top of that, we see a lot of non-fatal overdoses. So the problem goes beyond those who have died. The good thing is more people are being rescued with the use of naloxone. Naloxone is an antidote to an opioid overdose. It can help unblock the receptors that can allow a person to breathe again if they're experiencing an opioid overdose. And so naloxone, also called Narcan, is used by EMS officials, it's used by harm reduction experts, public health officials, and community members can buy it in the pharmacy and can get it at community-based agencies to try to decrease overdose.
Great. And so, Amanda, when you're working at Lowell House and you're seeing a lot of the people from our community that are battling addiction, tell us a little bit about what you've seen change, as we're seeing these numbers increase and use increase in our community.
I think, one of the things is we have to be more creative with individuals when we're trying to look at treatment and what's going to work best for them. With the presence of fentanyl that's been in the heroin on the streets, not just in Lowell, but across communities, it's really important that we do focus on these harm reduction techniques. And so the conversation shifting probably within the past 5 years from, you need to stop using drugs, they're bad for you, to how can we reduce your substance use? How can we make it safer for you? Conversations that I have on a weekly basis, are you using alone? If you're using alone, make sure you're using with someone. Don't mix your prescription medications when you're, specifically IV drug use. Things like that. Use clean needles. And so those are really the conversations that we're starting to have with people. And it's fantastic because I don't think that we've been doing that in the past. And sort of this idea maybe 5-6 years ago when no one wanted to talk about medication-assisted treatment, or MAT, which is Suboxone, Methadone, Vivitrol, and now that's kind of a norm. We talk about that in the addiction world, and so we're slowly but surely getting to that point where we're able to have these conversations with people with no judgment, and that's really what people need.
I think that's a key point that Amanda made. It's really a harm reduction model, and harm reduction is a non-judgmental approach that meets people where they are, both geographically, both in terms of their psychological and psychiatric current place in life, and in terms of what their needs are. But to reach out and acknowledge people are dealing with an addiction, which is a disease, but there are ways to reduce the risks associated with that disease.
And I'll just share, a story that a client that I've been working with an outpatient doing therapy, and then also coupling that with recovery coaching, which is a peer recovery support model. So, this individual's been, and the other thing I'll add is, a lot of people now are coming in and their drug of choice is fentanyl. It's no longer just heroin, it's fentanyl, which we know it doesn't take that much for someone to go into overdose. So this individual, they identify their drug of choice as fentanyl, and they were having a difficult time not using. And so one of the first things we talked about was medication-assisted treatment. So we were able to connect this individual to a clinic that provides medication-assisted treatment. And I see them weekly, and the recovery coach sees them 3 times a week. And so even though this person is not maintaining 100% sobriety, they're still connected to resources, and the likelihood that they'll be able to get into recovery, abstain from drug use is a lot higher than if we weren't able to get them connected to a medication-assisted treatment clinic, or they weren't connected to us. So I think
it's a key point. I mean, and research shows that folks that are within drug treatment programs, medication-assisted therapy programs, have decreased risk for sharing syringes, decreased risk for acquiring an infectious disease, decreased risk for overdose. So it can reduce their risk substantially and help to connect them to other services, which is essential. And I just wanted to hammer home the point that Amanda's made about fentanyl, right? Fentanyl is a synthetic opioid. It's produced by humans. It's not an opiate. It's not an opiate like heroin, which comes from plants, right? The opium flower. it is a synthetic that is produced by humans. But fentanyl is 40 to 50 times more powerful than heroin. So if somebody is using heroin and the heroin is cut with fentanyl, even a little bit of fentanyl, they might think they're getting their typical dose, but in actuality they're getting something much, much stronger. And that's what's contributing largely to the spike in overdoses and the increase in overdoses in the last few years in particular.
And I like too what you said about, you know, with kind of meeting someone where they're at, right? And there's a lot of misconceptions, I think, around some of our harm reduction strategies that are available in communities, that such as needle exchanges or drug-assisted therapies, that we're enabling, you know, someone who has an addiction, and we're making it more accessible for them to continue using drugs rather than, you know, having them stop drugs. Can you talk a little bit about, you know, that belief and that misconception and what is happening through these harm reduction strategies?
Sure. So the research doesn't substantiate that. There's been studies in San Francisco that looked at injection drug use patterns among younger populations before a syringe exchange program was introduced and after a syringe exchange program was introduced, and they didn't see increases in the number of people initiating drug use and injection drug use. So that's a myth that we often hear. You know, it's some kind of like the whole idea of having a designated driver, right? It acknowledges that a group of friends may go out and may drink, and some to excess. But having somebody who's being responsible, who can drive safely, can reduce the risks for the whole group. And so harm reduction programs can acknowledge that misuse is going to happen, but that it can decrease the risk that that person is going to share syringes, they're going to overdose, they're going to acquire an infectious disease.
So as far as the increasing diseases too in the community, most recently in the media we've been hearing about the spike in HIV cases. We're not really hearing about hepatitis, but we know that we're also, you know, seeing increases in hepatitis, and that typically goes hand in hand with some injection drug use. What are you seeing at Lowell House, and you know what is really happening behind that? And can you both talk a little bit to that?
Yeah, you know, as far as hepatitis C, I think, you know, it's unfortunate, but I think it seems to be one of those things that goes along with IV drug use. A lot of individuals, you know, that come to Lowell House that use drugs IV, a lot of them have hepatitis C. And what's great now, and I think we're not talking about it as much because there's actually medications that can cure hepatitis C. So, you know, I think the one that people generally talk about is Harvoni, which is a treatment for individuals that have hepatitis C that has good results. And I think, you know, as far as the HIV part at Lowell House, we do have a HIV outreach program that does case management, helps people that are positive for HIV get housing. You know, not only that program is doing that, but also getting the information out about PrEP, which is a medication that can be given to individuals that are at high risk of getting HIV. So individuals that are IV drug users, you know, individuals having unsafe sex, and the studies show that if an individual, you know, takes PrEP through sexual intercourse, their chances of contracting HIV is 90% less. And then for individuals that are IV drug users, it reduces it by 70%. So getting that information out to everyone and not just a small population is really important, especially, you know, when we know people are sharing needles and people are having unsafe sex, and it's important. And sometimes, you know, it's this taboo. We don't want to talk about it with people, and if we don't talk about it, then it's not happening. But really, it is happening, and we have to take initiative.
And you're hitting upon a key topic, which is the idea that we're seeing an opioid syndemic, right? At least these overlapping epidemics, right? It's not just about opioid use disorder. It's not just about opioid overdose, but it's also about hepatitis C, HIV, infectious endocarditis, which is an infection of the heart valve when bacteria is introduced into the body. And we've seen trends like this, increasing trends in the past 10 to 15 years in all of those diseases. And nationally, in Massachusetts, hepatitis C reports increased among 15 to 29-year-olds by 137% between 2003 and 2013. These are data from the Massachusetts Department of Public Health. We conducted a study where we saw nationally an increase in 15 to 35-year-olds in infectious endocarditis, which is tightly tied to injection drug use as well, so similar patterns. The HIV has been alarming, not only in Massachusetts, but in other parts of the U.S., and particularly we've begun to see spikes in HIV cases. First, in Scott County, Indiana, a very rural county of 4,000 people, they were seeing maybe a handful of cases a year, and then in 2015-16, they saw an increase to over 180 cases of HIV. And most of those folks were also co-infected with hepatitis C, and they were infected through syringe sharing of prescription opioid that was quite commonly distributed in the community. We've seen spikes in HIV cases in Kentucky, in West Virginia, and most recently in Lawrence and in Lowell. And in Lowell, we're awaiting the official numbers, but according to our colleagues at the Lowell Community Health Center, there was one new HIV diagnosis among a person who injects drugs in 2014. There were 2 in 2015, 3 in 2016, and then 24 in 2017. Again, we're awaiting the official report from the Massachusetts Department of Public Health, but that's alarming. That's approximately a 10-fold increase in new HIV diagnoses among people who inject. And in the past, we had seen pretty stable low numbers among people who inject because of prevention programs, harm reduction programs. So it's a reminder to us that HIV still is around. It lurks within our local communities. And if we let down our guard, if we don't continue with strong prevention programs, harm reduction programs, really using all the tools in the toolkit, it can raise its head again and impact our community in a significant way.
You know, I have the impression that we have a whole new generation of young people that weren't alive or active or using drugs in the 80s and 90s when HIV and hepatitis prevention and outreach was happening everywhere. And everyone knew how you could contract them and how you could stay safer. And then it seemed like communities got a handle on that and so moved on to other issues that needed prevention, education, and outreach. But I feel like we have this whole new generation that is HIV, hepatitis unaware. Are you seeing that too at Lowell House?
I think specifically in regards to HIV, HIV isn't one of those things that people really like to talk about. And so, we've been our HIV outreach team has really been talking about PrEP, how to stay safe, to reduce your risk of getting HIV. We provide contraceptives at Lowell House for individuals, and we have those conversations in our programs all of the time. There might be someone, just the other day, we had this conversation with clients, and the clients said, "I've never heard of PrEP." Right. And this is a room of individuals, that have been using drugs IV, or just, engaging in risky behavior. And so it's our job as providers to get that information out. People might not use it, but at least we're getting it out there. And we're really making people feel more comfortable about coming to providers and saying, like, hey, can you tell me a little bit more about the PrEP? Because I really think that maybe, I could benefit from that.
Absolutely.
Yeah, I think it's important to mention or define it for folks. It's pre-exposure prophylaxis. So it's using an HIV medication once a day preventively. prophylactically, so that their risk of acquiring HIV, if they're exposed to HIV, is greatly diminished.
Mhm.
And it can be a huge tool in the heterosexual community, among gay men, MSM, men who have sex with men. It could also be a big tool among people who inject drugs. And trying to provide increased access in a number of community locations could be particularly helpful. The whole idea of people who are young, who maybe are less aware about the ramifications of HIV and Hep C, as maybe we were when we were going through high school and the epidemic started, you know, in the early to mid 80s. And they didn't see, the youth of today or younger adults of today didn't see people wasting away with HIV. They didn't see people with skin lesions. They didn't see the drastic change in one's health over the course of very few years, because we do have antiretroviral therapies today. That's a good news too. If people are living with HIV, they can take antiretroviral therapies, which can prolong their life. There are many side effects associated with it, so it's not without challenges, but there are fantastic drugs. Previously, Amanda referred to the new direct-acting antivirals that are available for hepatitis C. That just came about in 2013, and they're fantastic medications. It can be once a day or a few times a day for 8 to 12 weeks, and 95% and above of the people who take the treatment are cured. And
Which is
that's
amazing.
huge.
And, you know,
Yeah.
10 years ago, it was so scary when we were hearing about new cases of Hep C.
Yeah, and it's huge not only for the folks who are being cured, right, and can go on to live a more healthy life, but also from a public health perspective, right? If we can reduce the number of people who are living with the virus, then we decrease the chance of an infected person coming into contact with a susceptible person. You know, public health 101, that's what we try to do, prevent people who are infected coming into contact with people who are susceptible. And so it can bring down community viral load and therefore have a kind of a herd immunity in trying to decrease overall prevalence of the disease in the community.
So I'd like to shift a little bit our conversation. So Tom, you are involved in a project here in Lowell with one of our community partners, the Life Connection, and also with UMass Lowell. And so I'd like you to talk a little bit about that project, how it came about, and what it is doing right now in the city.
Sure. So yeah, it's called Lowell Peers. Peers stands for Peer Education and Risk Reduction Services. I'm the lead on the project. We received funding from the University of Baltimore, which really funneled from the CDC to the Office of National Drug Policy and Control to University of Baltimore. We're fortunate to be one of 13 sites in the country that were funded. It is a collaboration with my colleague, Dr. Wilson Palacios, and Dr. Robin Tufts at the UMass Lowell campus here in town. Also with Jamie Dillon. She is the Executive Director of the Life Connection Center right here in town that serves warm meals Monday, Tuesdays, and Wednesdays, and provides a range of wraparound services to people of various backgrounds, including people who are in the throes of addiction. And we collaborate with folks from the Lowell Syringe Service Program, a mobile syringe service program. And together, we've developed a really strong camaraderie. This grant opportunity came about in the fall. And we linked arms, submitted a proposal, and we're fortunate to get funded. It's got multiple phases. The first phase is expanding and enhancing access to syringe exchange services and to overdose education and naloxone distribution at a brick and mortar site, that's the Life Connection Center, and at a mobile site, and that's with the Lowell Syringe Service Program. And we evaluate the program to gauge who we're serving, what types of services we're providing, and what types of referrals we can provide. Because a syringe exchange program is not only about getting dirty syringes off the street and getting sterile syringes out so that folks can decrease their risk of infection, both transmitting infection and acquiring infection, But it's also about connecting them to wraparound services, right? Like HIV and hepatitis C counseling and testing, like vaccines for hepatitis A, hepatitis B. Hepatitis A is foodborne illness, which any of us can get. Hepatitis B, bloodborne, it's passed through human body fluids. There's a vaccine for that. Get 2 or 3 injections, and you can be immunized. For Hep C, there's no vaccine currently, but there is the treatment, and we can help connect people to treatment as well. So those wraparound services are huge. That's phase 1 of the Lowell Peers program. Phase 2 is what we call RAP, a risk avoidance program. And it is a program that was developed at the Institute for Community Research in Hartford, Connecticut by Dr. Peg Weeks over a decade ago. And we're using that model to train peer educators. We call them peer health advocates. And they're folks who are still in the throes of addiction, but they're interested in not only decreasing their risk, but helping to provide services to the community within their peer networks. And so we'll train them at HIV prevention, hepatitis C prevention, sexually transmitted infection prevention, and overdose prevention. And then they'll go out, once they're trained, to reach out to their peer members to expand knowledge within their peer networks and hopefully decrease risks. We also have a third piece of the program, which is our CAB, or our Community Advocacy Board. And we have strong representation from public health, from law enforcement, from community-based agencies, from shelters, healthcare centers, and hospitals here in town. And so in that group, we present on how things are going with the project, but we also seek and are always glad to receive feedback. How can we do better? What's the current reality, and how can we expand on our impact?
And thank you. And Amanda in Lowell House is part of that board,
Yes.
as well as the Lowell Co-op team, which is the community opioid overdose outreach program. Sorry. And Amanda is one of the supervisors of that team. So if you can just give us, just as we're wrapping up, just so that the people at home know a little bit about, the co-op team and what it's doing here in the city.
Yeah, so the team consists of a Lowell firefighter, a Lowell police officer, 2 Trinity EMS providers, and an addiction specialist at Lowell House. The program, they set out to respond after someone has overdosed. So we know that that's a key intervention point for individuals. If someone overdoses, we have an opportunity to get them into treatment. So the co-op really has been boots on the ground in Lowell, knocking on doors, calling individuals and seeing how they're doing, what they might need. Do they need to go to detox? Aside from that, there are 2 recovery specialists who are office-based, but working with the co-op team to actually follow these individuals through.
So thank you both for being here today and
pleasure.
for sharing
Pleasure to be here.
your different projects and certainly your expertise. And I know that the Lowell Health and Human Services Department and the city certainly value your input and the time that you work on your projects that help everyone here. So thank you for that.
Thank you, Karen. Thanks for your leadership. Look forward to our continued collaboration.
Thank you. So if you have any questions that you heard something today from the show or from one of our guests, you certainly feel free to reach out to the City of Lowell's Health and Human Services Department. We have a substance use and prevention department there. And we would be, happy to answer any questions you have, or if you would like to get more involved to help people in our community, that's a great place to start to reach out. Thank you for being with us today. Goodbye.